As you can imagine, this is going to be a lecture on bleeding and clotting, and of course clotting drugs. Hemostasis is the process of stopping blood, so hemo, blood, stasis, still. So stopping bleeding. Essentially, there's going to be three components to this. We're going to have platelets being activated. We're going to have clotting and coagulation factors, collectively known as the Clotting Cascade, and then we're going to have blood vessels involved. So first we have to talk about the control of hemostatic mechanisms. So a normal blood vessel actually has properties that prevent clotting. So there's a smooth texture of the endothelial lining of the blood vessels, and there's a negative charge on the endothelial wall proteins. And what that's going to do is kind of going to push platelets and clotting factors away from the edge of the blood vessel toward the center. Once damage has occurred, it's going to destroy the vascular endothelium, sometimes directly, exposing whatever's underneath the extracellular matrix. That, in turn, is going to attract those clotting proteins and platelets. Also, once there's been damage done to the endothelium, the nearby endothelium will become activated. And once it's activated, then it's going to start secreting pro-clotting enzymes and cytokines, which in turn are going to induce platelets to activate and also helping to activate the clotting cascade. Now, once the clotting cascade is activated, immediately, almost concurrently, there's going to be an activation of anti-clotting mechanisms, because the last thing you want to do is have a clot that grows to the size of the moon. You want to have a small clot, control it, stop it, and then degrade it once it's no longer needed. So let's talk kind of a brief overview of the sequence of events. The first thing that's going to happen when there's damage is you're going to have vasoconstriction or vasospasm. That in itself is going to slow blood flow to that area. Then platelets are going to activate and aggregate, and they're going to hold hands. That's going to form what's called the platelet plug, or sometimes called the primary plug. Then concurrent with that, you're going to have activation of the clotting cascade. There's two basic pathways, intrinsic and extrinsic. Extrinsic pathway is actually the one that is more commonly used inside the body in response to vascular injury. No matter which pathway is activated, the final pathway is going to end up causing fibrinogen to be cut open into fibrin. Fibrin, in turn, is going to tie the platelets together, forming what's called a stable clot, or the secondary plug. And then fibrinolysis is the beginning of destroying the clot. So remember, fibrinogen turns into fibrin, and when you break fibrin, fibrinolysis is going to break down that fibrin. This is a brief and simplified view of the coagulation cascade. So when you have tissue damage, is actually not shown here, is tissue factor, which is inside of the endothelial cell. It's actually in the membrane of the endothelial cell. So when that cell is damaged, it's going to release tissue factor. Tissue factor is going to combine with factor 7. Then collectively, they are going to activate factor 10 to factor 10A. Factor 10A combines with factor 5, and that in turn will cut prothrombin into thrombin. Thrombin is going to cut fibrinogen into fibrin, and fibrin is what holds the platelets together, making the plot more stable. So you need to be able to say that. So let's say it again, shall we? When an endothelial cell is damaged, it's going to release tissue factor. Tissue factor gets together with factor 7 and cuts factor 10 into factor 10A. Factor 10A gets together with factor 5, which in turn is going to cut prothrombin into thrombin. Thrombin is going to cut fibrinogen into fibrin. Fibrin is going to bind to platelets, causing a stable plaque, stable clot. In addition to the extrinsic system, there's also what's known as the extrinsic system. Extrinsic system is going to start with factor 12. Factor 12 has to be exposed to a negatively charged substance, such as glass is how we test for it. That in turn is going to cause factor 11, and that's going to cut this factor, and then that factor is going to cut that factor, and then they're going to cut. And you'll notice that it ends the exact same way that the extrinsic system worked. The intrinsic system takes a little bit longer to get going and to function than the extrinsic system does. One last note, the distinction between extrinsic and intrinsic is a little bit artificial, and really the only true usefulness of its purpose is to tell you which of these is going to be inactivated by heparin versus going to be inactivated by warfarin. So when you use warfarin, you're actually going to inhibit the extrinsic system primarily. When you're using heparin, you're going to be inhibiting the intrinsic system. So let's talk a little bit about these little platelets. So platelets are cell fragments that come from megakaryocytes in the bone marrow. They don't have a nucleus, so they're not true cells, and they are not metabolically active in the sense that they can create new proteins. So whatever they're born with is all they've got until their little meager 7 to 10 day lives are done. Now, collagen is going to be in the subendothelial tissue. So basically, when endothelium is destroyed or damaged, the extracellular matrix behind it is going to be exposed, and there's a lot of collagen there. Platelets are attracted to collagen, and they're able to bind to it. So typically, within 15 to 20 seconds, platelets are going to be attracted to that vessel injury site, and they're going to begin to fill in the endothelial gaps. As they do this, they're going to degranulate. So platelets don't have any DNA, any nucleus, partly because they're filled with these little granules full of substances that are going to help them do their job. So when they become activated, they are going to degranulate, which is going to release those little substances into the nearby plasma, which in turn is going to affect the behavior of nearby platelets and other cells, and it's also going to help begin the clotting cascade. Things that are released by the platelets include serotonin and histamine, which are going to help cause vasoconstriction nearby and promote platelet degranulation of other platelets. So basically, when one degranulates, they all degranulate nearby, which is kind of like dominoes. Another thing they're going to release is they're going to release thromboxane A2. Now, thromboxane A2, despite the name, is actually a prostaglandin. So in order to produce thromboxane A2, we actually have to combine arachidonic acid with, that's right, cyclooxygenase 1. So thromboxane A2 is actually a prostaglandin being produced by the platelet. And that's going to cause two major things. The first one is vasoconstriction, and the other one is nearby platelet degranulation. The next product is ADP. Yes, the exact same stuff that ADP turns into ATP. ADP is going to stimulate platelet aggregation by causing the plasma membranes of the platelets to become ruffly and sticky. So imagine for a moment that your normal platelet looks kind of like that. When they try to stick to each other, there's not much surface to do the sticking. So what would happen if we change the shape to be something like this? Now there's more places for them to stick to one another. So that's what we're talking about when we say it becomes ruffly and sticky. As far as sticky goes, they're going to express certain molecules on the cell membrane, which are going to allow them to stick both to one another and also to stick to the vascular wall. These last two items you don't need to remember because they're just going, I mean, that's just for kind of completion's sake. So platelet factor 3 is going to stimulate coagulation cascade, and then platelet factor 4 is called heparin neutralizing factor, and heparin is an anti-clotting agent. So basically, when a platelet wants to clot, it's going to neutralize the nearby anti-clotting chemicals. Okay, now there's basically three platelet functions. The first one is to stick to stuff. Collagen and extracellular matrix in the blood vessel, and another platelet on the other side. One of its jobs is to activate, which is going to be to degranulate and become metabolically active. And then the final one is the platelet aggregation, where they begin to stick to one another. So a little bit of detail on adhesion. In order to adhere, remember, it has to express certain molecules on its cell membrane. So it typically is going to stick to something known as von Willebrand factor on the vascular wall, and it's going to stick to platelets. In order to be able to stick to platelets, there has to be an ADP activation on platelet receptors. When it comes to activating, remember, they're going to change their shape, and then they're also going to express those adhesion molecules. And then you're going to get activation of the arachidonic pathway. So arachidonic acid, in the presence of cyclooxygenase 1, is going to release thromboxane A2, which is a form of prostaglandin. The final platelet function is platelet aggregation, where they're going to begin to stick together. And so that's induced by the release of thromboxane A2, which again is a prostaglandin that is produced by platelets themselves. And that's going to cause a platelet plug. Also going to, when platelets are activated, they're also going to induce the clotting cascade, which is going to help tie themselves together with fibrin. Now, an interesting thing that also occurs is prostacyclin, which is another form of prostaglandin, is released from endothelial cells. So under ordinary circumstances, endothelial cells produce prostacyclin, which is going to cause vasodilation and inhibit platelet degranulation. So during endothelial activation, when there's been endothelial damage, there's going to be a decrease in prostacyclin. Now, this explains why aspirin works. So if you recall, platelets do not have DNA, so they can't produce more cyclooxygenase. So they can't produce more. They can't once aspirin binds to cyclooxygenase on the platelet, it can never ever be used again. Whereas in the endothelium, when aspirin binds to its COX-1, it has a nucleus. It can produce additional COX-1. So when you give relatively low doses of aspirin, 81 milligrams to 325 milligrams, what you're doing is you're selectively inhibiting platelet COX, but you're not really inhibiting prostacyclin production by endothelial cells. Kind of cool, huh? That might be a bonus question. Just saying. One thing to note is that platelet functions, in particular the clotting cascade functions, are calcium dependent. And so if you inhibit calcium, or if you have low calcium, then you're going to reduce the amount of clotting, which is one of the reasons why packed red blood cells are packed with citrate. Citrate binds to calcium and prevents it from allowing clots to form. Now, once the platelet plug has been formed, the platelets will actually change shape and kind of pull together, and that's going to pull the edges of the injured vessel together. Then you want to dissolve the clot, and that's going to occur by thrombin plasminogen activators, which are plasminogen is basically scissors, and the scissors are going to cut fibrin. So let's talk about the clotting cascade in a little bit more detail. So anytime you see cascade, you need to think a series of enzymatic reactions of zymogens. Remember, a zymogen is an enzyme in an inactive form. In order to make it active, you have to cut part of it off. That's called cleaving. Anytime you cleave an enzyme, you're going to have an A side and a B side. So sometimes the A side is active, sometimes the B side is active. Doesn't matter. In the clotting cascade, the A side is always the one that's going to be the active side. But sometimes the B side will have an other effect, such as increasing inflammation. But the A side is the part that does the work in terms of allowing the clot to form. So remember, the ultimate end result of the clotting cascade is that fibrinogen is going to be cut into fibrin, and that's going to cause a meshwork of protein strands that stabilizes the platelet plug. An interesting thing about this is that fibrin doesn't just bind to platelets like this, but there's also cross bridges that form as well. So basically, there's going to be platelets all over the place with fibrin going all over the place, cross-bridging and cross-linking with itself. So that clot becomes extremely stable because there's this like gel of fibrin. One important thing to note is that all of these clotting cascades are proteins. So if there's protein malnutrition, there's going to be fewer of them, which is in turn is going to lead to increased risk for bleeding. Okay, so let's talk just a little bit about cutting the clot down. So remember, we don't want the clot to keep growing forever and ever or to stay there forever. Once the damage has been repaired, we want to get rid of the clot. That's going to be called fibrinolysis or thrombolysis. They're the same process, just two different names. So in order to cut fibrin, we need a pair of scissors. And those scissors are going to be called plasmin. So plasmin is a proteolytic enzyme, meaning it breaks protein. Fibrin is a protein. So plasminogen is going to turn into plasmin, and then plasmin will destroy the fibrin. All right, so let's talk a little bit about how we can monitor coagulation ability. The first one is in platelet count. It can be normal, it can be high, or it can be low, obviously. Higher platelet counts tend to be associated with increased risk of clotting, whereas lower ones are associated with increased risk of bleeding. Makes sense, doesn't it? Then we have what are known as partial thromboplastin time, PTT, and prothrombin time, PT. Now, PTT measures intrinsic pathway, whereas prothrombin time measures extrinsic pathway. Now remember we said this distinction is a little bit artificial. Well, this is where the artificiality comes, in that we're able to measure them separately, so we can use them to assess the therapeutic nature of our drugs that we're going to give. So PTT is associated with heparin. PT is associated with warfarin. Now, we've got to talk briefly about international normalized ratio. So, you see right here under PT where it says it's about 12 seconds? So, if you take 12 and you divide 12 by 12, then you get a ratio. And if you reduce that ratio equals 1. So, whenever you talk about PT, we don't ever really interpret the number of seconds. What we do is we're going to divide it by the appropriate denominator, which is determined in the lab. It varies by lab to lab. And then that is going to come up with something known as the International Normalized Ratio, or INR. So a 1 is exactly normal. It's what you expect. You expect to have 1 divided by, any number divided by itself is 1. So if the number is what you expect it to be, it's 1. So it's actually very simple to interpret. If the patient's INR is 2, that means it takes twice as long to clot as normal. If it's 3, then it takes, you guessed it, 3 times as long to clot as normal. So the higher the INR value, the higher the risk of bleeding. Now, if a patient is clotting too much and you're giving them anticoagulants therapeutically, then what you want to see is an increase in INR. In addition to the platelet count, the PTT, and the PT-INR, you also have some other measures. And those are primarily going to be things like protein level, fibrinogen level, levels of certain clotting factors, etc. There's also some other markers in terms, primarily inflammatory markers that you can look at, which will indicate the kind of the coagulable state of a patient. So remember, coagulation is going to be regulated by cytokines, so you can test for those cytokines to see if they exist or not. Okay, now you'll recall that we said platelets are going to tie themselves together with fibrin. So they don't just tie themselves to any old place. The fibrin actually has to bind to a certain spot. So if you ever remember what a carabiner is from rock climbing, that's kind of what the receptor is. This receptor is known as a GP2B3A receptor. In its inactive form, it's 2B. In its, get it? It's 2B. It will be in the future. And in its active form, it's 3A. So fibrinogen can only bind to an activated 3A receptor. GP stands for glycoprotein. It's extremely important because we have drugs that can inhibit these receptors from activating. Coagulopathies are bleeding disorders, and we're talking about those very briefly now. Some general manifestations of bleeding. So if the bleeding is under the skin, then you typically will have ecchymosis, which can be red, purple, blue, black, little greenish yellow, and those changes in color are going to be mediated by the breakdown of blood. So originally you get breakdown of blood turns into bilirubin, hemosiderin, you get the idea. So that's where those color changes come from. Now, smaller amounts of ecchymosis might be known as purpura, which is typically a reddish purplish color, and then petechiae, which are less than 0.5 centimeters. The bleeding could also form a hematoma or a mass underneath the skin. If you've ever seen someone, or if you've ever experienced this yourself, where you got hit on the head and you got that goose egg forming, that goose egg is actually bleeding under the skin. A hematoma. So you can also have hemorrhaging, and so here's some common places to hemorrhage from, and you do need to know these descriptive terms. So epistaxis is nosebleeds, hemoptysis is coughing up blood, hematemesis, that just makes sense, hema, blood, emesis, vomit, blood vomit. Coffee ground emesis is when you vomit up digested blood or old blood. Hematochezia is when there's bright red blood in the stools, so that's going to be fresh blood. And then melena is dark tarry stools, which is indicative of digested blood. There are some drugs that can actually mimic melena, which include iron sulfate itself, and also Pepto-Bismol. Okay, so when it comes to problems with platelets, we can have too many or too few. We can also have platelets that are not formed correctly. So any platelet count that's lower than 150 is going to be considered thrombocytopenia. Now, even though thrombocytopenia occurs at that level, it's not necessarily clinically relevant. So it's low because it's less than the normal value. Remember, normal value is just two times the standard deviation from average. But you still have pretty normal function. Once you get down to 100,000, you're beginning to get a little bit more concerned. And in fact, if the patient has to go for a procedure, they might defer the procedure till later. This is going to be especially important for those of you who want to do labor and delivery, because if platelet count goes below 100,000, the woman can't get an epidural. Once you go below 50,000, they start becoming fairly high risk for bleeding potential. You definitely need to implement bleeding precautions at this point. And once they go below 20,000, they are at high risk for spontaneous bleeding. We're going to talk about two causes right now. The first one is something known as HIT, heparin-induced thrombocytopenia. Heparin is an anticoagulant drug, and sometimes there's going to be an allergic reaction, which is going to result in antibodies that target platelets. The platelets are all destroyed, and now you'll start bleeding, causing purpura. The second one is idiopathic thrombocytopenic purpura. So in this case, we don't know what's causing the thrombocytopenia, but something is causing it. So remember, the word idiopathic means we have no idea what's causing it. A lot of times in idiopathic thrombocytopenic purpura, the treatment that solves the problem is to remove the patient's spleen. Remember that in the spleen, about 2/3 of the platelets in the body are being held in reserve, and platelets are responsible for getting rid of old, unused platelets. So by getting rid of the spleen, sometimes you can solve that idiopathic thrombocytopenic purpura. On the other hand, we can have too many platelets, and there's a couple different reasons for that. So one of them is what's called primary hemorrhagic thrombocytosis. So basically, it's a disease where the megakaryocytes overproduce the number of platelets. You can also have secondary thrombocytosis, which is as a result of something else. So remember in the last slide we said if your spleen is getting rid of too many of the too many platelets, you can remove the spleen. Well, in patients who don't have a spleen, they don't have anywhere to store those extra platelets. So now those extra platelets are floating around in the blood. Cancer and arthritis can also cause excess platelets. Blah, blah, read it. Now we're going to talk about coagulation disorders that are caused by clotting factor problems. So the first one is vitamin K deficiency. Vitamin K is necessary to produce 5 of the clotting factors. So if you don't have enough vitamin K, you're not going to be able to make those clotting factors in high enough quantities. The next one is disseminated intravascular coagulation. We already learned about that for test 3. So remember, DIC is when you have clotting that is spread throughout the body in the blood vessels, disseminated, spread throughout, intravascular inside the blood vessels. So because you're causing these little microclots all over the body, you're using up platelets and clotting factors very, very quickly. Once you've used up all the clotting factors, you begin to bleed to death. DIC. Also the mechanism for hemorrhagic fevers such as Ebola virus. The next one is liver disease. All of the clotting factors are proteins, so if you have liver disease, then you're not going to be able to make those proteins well enough. Then we have something known as thromboembolic disease. Thromboembolic disease is actually the opposite problem. You're going to clot when you should not clot. You're going to clot inappropriately. We'll talk about those separately. And then we have hemophilia. Hemophilia is when you're missing genetically the ability to make one or more clotting factors. The most common form of hemophilia is associated with sex-linked reproduction. So it's on the X, not the Y. So if you remember your Punnett squares, what that means is the woman is typically a carrier who passes it along to her son. The son has the disease, and he's going to pass the trait, sorry, not the trait, he's going to pass the gene, because he only has one X and that X is defective. He's going to pass that X along to all of his daughters, who will then become carriers who can give it to their sons. So vitamin K deficiency, you can read all about it right there. Pretty self-explanatory if you ask me. I briefly described DIC a little bit earlier. Here you can see some of the details about it. Again, it's pretty much self-explanatory. All right, let's talk a little bit about the manifestations of DIC. So the first one is going to be bleeding, profuse bleeding. In order to stop the bleeding, typically what you're going to have to do is give huge amounts of platelets and fresh frozen plasma. Fresh frozen plasma is going to replace lost blood volume as well as provide albumin, which is going to help pull fluid back into the blood vessel, and it's also going to provide clotting factors. So fresh frozen plasma does it all in this case. In addition to the fresh frozen plasma, they will almost always also need infusions of packed red blood cells. It's not uncommon to give up to 20 units of fresh frozen plasma and packed red blood cells to a patient who's having septic shock DIC. When it comes to treatment of DIC, supportive care, you got to basically manage their circulatory system, make sure that they have enough blood to be able to pump. So that comes in with all those fluids. Treat the underlying disorder. If it's because of pregnancy, you got to get that kiddo out of the womb. If it's because of sepsis, you're going to give antibiotics. Early on, before the DIC has become full, you can use heparin, which is still controversial after 30 years, to help prevent that initial clotting, which will help prevent the clotting factors from being used up. Now we're making it into the home stretch. We've got thromboembolic disease. Thromboembolic disease is any disease where you have abnormal clots forming inside of a blood vessel. So a stationary clot is known as a thrombus, and an embolus is a clot that is broken free and is now floating around in the blood and will eventually be deposited in an arterial bed. So if you think about it for a moment, let's imagine you have a clot in your leg. That clot breaks off. It's going to go up your leg into the inferior vena cava, from there into the right atrium, the right ventricle, the pulmonary artery, and then it's going to lodge in the, that's right, lung, causing a pulmonary embolism. Abnormal clots are typically associated with Virchow's triad, which are factors that favor clots. And the three of them are loss of integrity of the vessel wall, typically atherosclerosis in arteries, abnormalities of blood flow, which is typically going to be either sluggish or turbulent. Sluggish tends to be in veins, turbulent tends to be in arteries. And then alterations in blood constituents. So if you have too many platelets or a prothrombogenic state. Here are some of the common diseases or conditions that can be caused by thromboembolic disease. The first one is myocardial infarction, better known as a heart attack. So basically you have a plaque, atherosclerotic plaque that breaks open, inducing a clot. The clot is going to prevent blood flow to the heart, at least part of the heart muscle, thereby causing ischemia in that part of the heart. Stroke. Basically, the same thing happens, except instead of being in a coronary artery, it's happening in your brain. A DVT is a deep venous thrombosis, so basically it's a blood clot in the deep veins of the leg. DVTs below the knee are rarely dangerous. The ones that form in the upper leg, so from the knee to the hip, are typically the ones that are more likely to become pulmonary emboli. And that is the next one. PE is pulmonary embolism. Extremely life-threatening. Extremely life-threatening. DVT is the major risk factor for a pulmonary embolism. Now, one of the nasty things is that DVTs are about 50% of the time completely asymptomatic. So a lot of times the first clue that we have that the patient actually has a clot is that they end up with a PE. AAA stands for abdominal aortic aneurysm. An abdominal aortic aneurysm is a weakening in the arterial wall of the aorta in the abdominal area. So it's after the arch of the aorta when it's on its downward descent toward the renal arteries and iliac. When that happens, there's typically going to be a lot of clotting occurring because as the walls pouch outwards, there's little areas that the blood can kind of pool and stay still. Still blood tends to clot. The next one is AFib, or atrial fibrillation. So the atria's job are to coordinate with the ventricles, and just before the ventricles contract, the atria contract, and that's called atrial kick. The atrial kick is going to provide about 30% of the end diastolic volume, the amount of blood in the heart before the ventricles constrict. So when you have atrial fibrillation, you're losing that atrial kick. You're losing about 30% of the end diastolic volume. Where does that extra blood go? It stays in the atria. So atrial fibrillation is associated with pooled blood in the atria, which in turn is at risk for clotting. The main therapy for thromboembolic disease is going to be drugs: anticoagulants, antiplatelets, and thrombolytics. Anticoagulants are drugs that inhibit the clotting cascade, and they're best against venous thrombi. Antiplatelets inhibit platelet function and are best against arterial thrombi. And then thrombolytics are going to dissolve existing thrombi. So anticoagulants and antiplatelets don't actually stop or destroy an existing clot. What they do is they prevent that existing clot from getting bigger. When it comes to prevention of thromboembolic disease, in addition to the drugs that inhibit clotting, you can also treat the underlying disease, and you can also maintain adequate circulation. That's especially important for venous clot formation. When it comes to anticoagulants, the classic separation is drugs that inhibit the intrinsic pathway, which is heparin and heparin-like drugs, and then extrinsic pathway inhibitors, which is primarily going to be warfarin. There are some newer ones out there that don't necessarily have to have this artificial classification, so we'll talk about those a little bit later. Those are called direct thrombin inhibitors. The key difference between intrinsic and extrinsic is that with intrinsic pathway drugs such as heparin, you're going to monitor PTT, whereas with extrinsic pathway, you're going to monitor PT/INR. And in fact, INR is the actual number you need to know. Okay, first we're going to talk about heparin. It's the oldest one, and sometimes it's known as unfractionated heparin. The reason why it's called unfractionated is because there are a variety of different heparins that get lumped together. Because they're lumped together, there's different fractions of different weights of heparin. It's also available as a low molecular weight heparin, which is a more standard heparin where they're all the same size. And, as the name implies, they're going to be smaller because they're lower weight. The way that heparin works is it's going to enhance the action of antithrombin, and it's going to inhibit thrombin and factor Xa. Low molecular weight heparins are only going to prevent factor Xa. This little figure is kind of like an illustration of how heparin works. So right here we have the active portion of the heparin. Right here we have the antithrombin molecule, and you'll notice that heparin gets together with antithrombin. Then it's going to bind to factor Xa like this. Pretty simple. Now, the way that low molecular weight heparins work, same thing, but you'll notice that this tail is much shorter. That shorter tail is going to provide a number of benefits to low molecular weight heparins, which we're going to talk about in a little bit. So heparin is going to work here and here, and low molecular weight heparins are only going to work here in factor 10A. Okay, let's talk a little bit about unfractionated heparin now as far as the drug goes. So it's absorbed only by injection. It's typically going to be given IV or subcutaneous, never IM because of high risk of bleeding. It cannot cross the blood-brain barrier or placenta or milk ducts, which makes it very safe for pregnant women and breastfeeding women. Its availability in the plasma, it's going to bind to plasma proteins and monocytes and endothelial cells, and as a result, it's going to have a wildly varying therapeutic levels. It's going to vary from patient to patient, and it's going to vary within the same patient from hour to hour. So it's going to require careful monitoring. It's got a very short half-life, which means that if it goes too high and becomes toxic, you can pretty much just discontinue the drug, and within a very short amount of time, they're going to be subtherapeutic. So you very rarely have to ever give an antidote to heparin. As far as the time course of the effects, what you're typically going to do with IV therapy is you're going to start off with a bolus, which is an injection within a syringe, and then you're going to begin a drip. So the bolus is going to be in a syringe. You're going to draw it up from a little vial, and you're going to push it into the patient's vein through the IV. The bolus drip is a bag, and you're going to connect that bag up to the patient's IV. And that's going to drip in continuously over time. When you give it IV, the therapeutic action is going to start within seconds, and then again, as we said, when you discontinue it, the effects rapidly fade. Within 30 minutes, most of the therapeutic effect is gone. Some uses that we can use heparin for: pregnancy, pulmonary embolism, DVT, evolving stroke, so a current stroke that's happening, open heart surgery, dialysis, DIC, again, that one is controversial, and acute MI as an adjunct, not as the primary drug. Primary drugs are going to be antiplatelet drugs. As you would expect, the first adverse effect is bleeding. There's also something known as heparin-induced thrombocytopenia. Essentially, what happens is there's going to be antibodies created against the heparin that are going to bind to platelets, and then that's going to destroy platelets while increasing clotting. So even though the patient has low platelets, they actually have a hyperthrombotic state. If a patient ever has heparin-induced thrombocytopenia, they can never get heparin again, nor can they get a low molecular weight heparin. Patients can also have hypersensitivity reactions, and then there's an extreme risk of neurological injury with certain surgeries. So never ever use heparin for neurosurgeries. Be very, very careful with patients who are already at high risk of a bleed, and it's contraindicated in patients who have thrombocytopenia, makes sense, uncontrolled bleeding, makes sense, surgery of the eye, brain, spinal cord, and lumbar, and regional spinal anesthesia. Now, what do all of these things have in common? Highly neurological, and neurologic injury with surgery. Oh, right, got it. It interacts primarily with other anticoagulant drugs, including antiplatelet drugs. Protamine sulfate inactivates heparin, and it is the antidote to heparin overdose. Although, again, we said most of the time you don't need it. All you have to do is discontinue it. As far as lab monitoring goes, you're going to monitor the PTT level. Normal values are about 40 seconds, and therapeutic range is about 60 to 80. You're going to typically monitor the patients every 6 hours until the patient's stable. When the patient has had 2 stable PTT readings, so it's going to be 6 hours and 6 hours, 12 hours apart, they've had 2 stable readings, then you can go up to every 8 hours. And believe me, 8 hours is much better than 6 hours, because 8 hours can happen just once a shift, whereas every 6 hours is guaranteed to be twice a shift. And it's one of those things that when you have 5, 6, 7, 8 patients, it's just one little extra thing that can go wrong. It's very time sensitive. You have to make sure that it gets drawn on time. You have to make sure that you read it on time. You have to make sure that you adjust it on time. It's very easy to let it slip and end up with med errors. It's a very, very dangerous drug. Not enough, patient is at risk of clotting. Too much, patient at risk of dying from bleeding. It's not that easy. Being cheesy. So the dosing for heparin is in units, not milligrams. There are different concentrations, so you've got to be very, very, very careful which concentration you're supposed to give. Concentrations can range from 1,000 units per milliliter all the way up to 40,000 units per milliliter. It's an easy way to kill someone by accident. Don't do it. Don't do it. When you give it IV, typically you're going to give it continuous, and it's going to have to be on a pump. You're never allowed to use a gravity drip and then calculate the number of drops per minute. You can also give subcutaneous, and when you give subcutaneous, it's typically going to be a low dose, 5,000 units, and it's typically going to be given every twice a day or 3 times a day. When you're giving low-dose heparin, BID or TID, then it is not for treatment. It is only for prevention of DVT. So if you have a patient who has a DVT, you will not give 5,000 units subcutaneous BID. No, no, no. No. Bad nurse. You're going to give IV heparin for an actual clot. If, however, all we're trying to do is prevent a clot, say a patient who's had a surgery and is at risk for a DVT, then you're going to give 5,000 units subcutaneously, BID or TID, depending on the patient's weight. When you give low dose, you typically do not have to monitor PTT. And that is going to be for subcutaneous only. Now we're going to talk about low molecular weight heparins. They are as effective as unfractionated heparin, however, they don't have a lot of the downsides. They don't bind to monocytes and proteins, and they have a longer half-life. So you can administer them twice a day, subcutaneously, and you don't have to monitor PTT. And they work just as well, if not better. There have been several research studies that show that low molecular weight heparins are more effective than heparin. And I think probably a lot of that just has to do with decreased errors in how they're given. The only thing you really need to know about how to dose it is how much your patient weighs, because they are dosed by weight. They're given subcutaneously only, we already said that. And as far as the adverse effects, you should see that they look very similar to heparin. And they are, but it is safer. It's much less likely to cause thrombocytopenia than heparin is. The one you're going to learn is enoxaparin or Lovenox, and it is by far the most common low molecular weight heparin. All right, let's talk a few other drugs. So we have fondaparinux, which is a heparin-like drug. It is going to inhibit factor 10A, and it's going to have a very, very, very low risk of heparin-induced thrombocytopenia. It's primarily used in patients who are at risk of heparin-induced thrombocytopenia who would ordinarily take heparin or low molecular weight heparin. These direct thrombin inhibitors are not used as often anymore. There are 2 newer ones out on the market. The brand names are Pradaxa and Xarelto with an X. I'll post a text comment here that will have the names of them. And then I'm going to provide you an article, or actually 2 articles, that you can read so to be ready for the test. The main use of Pradaxa and Xarelto is for patients who have atrial fibrillation. They are oral agents, and they can be used outpatient. Up until the development of Pradaxa and Xarelto, warfarin was really the only oral anticoagulant in common use in the United States. It's still very common. There's a lot of patients who have been on it for a long time, and they're stable on it. There's a lot of doctors who are very comfortable prescribing Coumadin or warfarin, and they know how it works. They know what to expect. They like to be able to monitor the INR. Whereas with Xarelto and Pradaxa, they're much newer drugs. There's not as much data behind them. There's not as much evidence that supports their use in terms of patient mortality. So let's talk about warfarin. The way that warfarin works is it's going to inhibit the production of these yellow highlighted drugs. Clotting factors. Those particular clotting factors are produced in combination with vitamin K. Essentially, the way that warfarin works is by antagonizing vitamin K. You'll notice that factor 7 is really the only thing combined with tissue factor. Tissue factor comes from the endothelial cells, which you'll recall from a little bit earlier. So tissue factor gets together with factor 7, and that is going to convert factor 10 into factor 10A. By inhibiting the production of factor 7, you directly inhibit this entire pathway. That's why warfarin is called an extrinsic pathway inhibitor. Warfarin is very easily absorbed in the stomach, which is good for an oral drug. 99% of it is bound to protein in the blood. That's going to make it a little bit unpredictable sometimes. It readily crosses the placenta and milk ducts. It is not to be used in pregnancy. Again, it is not to be used in pregnancy. There's a very high risk of deformities. Even though it crosses into the milk ducts, it is typically considered safe for breastfeeding. And then finally, it's going to be metabolized in the kidneys in the liver, and then excreted. Now, though warfarin begins working almost immediately, it has no effect on existing clotting factors. So it's going to take 2 to 5 days before it reaches a therapeutic effect, because you have to use up those existing clotting factors first. So you need to cover the interim with a parenteral anticoagulant, such as heparin or enoxaparin, or a Rixtra, fondaparinux. So this little thing where it says comedy of errors, I clearly remember when I was a nursing student at Shands at UF, there was a patient who had a clot while he was in the hospital, and he had been on heparin, and then he had been prescribed warfarin, and someone discontinued, somehow, someone, somewhere discontinued giving the patient heparin. So he was there with no anticoagulation for about 3 days, and he had a clot during that period. And one of the doctors in the patient's chart wrote that it was due to a comedy of errors. Now, never ever write that in a patient's chart, first of all. But it was just so funny that I kept it with me for the rest of my life. If you get sued and you put comedy of errors, you're going down. Now, warfarin will interact with almost everything, including the kitchen sink. So there's a lot of interactions you got to be aware of, and patients should typically be told don't start or stop any drugs without first consulting your doctor. In fact, you shouldn't even change your diet in terms of vitamin K intake. So the reasons why we use warfarin: it helps to prevent DVT. It also helps to prevent pulmonary embolism from DVT. And it can also help prevent clots in patients who have mechanical heart valves. Mechanical heart valves are extremely pro-thrombotic. Basically, there is a little wire cage, And then there is a ball that's going to travel up, up, and down inside that little cage. And as it does so, it's going to pinch red blood cells in between the cage and the ball. And when that happens, it's going to release a number of substances which are going to induce clotting. And then prevention of thrombus in atrial fibrillation. In addition to these indications, there are also off-label uses to reduce the number of TIAs, which are sometimes called mini strokes or sometimes called precursors to a stroke. And then finally, we have reduce the recurrent MI. So if a patient has had an MI, they've been acutely treated, they didn't die, now they're going to be put on warfarin, typically for about a year or more, to help prevent another MI from occurring. When it comes to monitoring, what you're going to monitor is the INR. So therapeutic INRs are typically 2 to 3. So for everything that we listed on that last page, except for mechanical heart valves, 2 to 3 is the therapeutic range. For mechanical heart valve patients, the range is 3.5 to 4.5. Now, I do have to mention one small little detail here, and that is that there are two different agencies that make recommendations regarding mechanical heart valve anticoagulation. And one of those says that the therapeutic value should be 2.5 to 3.5. And the other says it should be 3.5 to 4.5. So this is the one I knew about first, and that's the one we're going with. For your test, 3.5 to 4.5. But if you go out there into the hospital and you see different values, I got you covered. Now, when you start a patient on warfarin, typically what you're going to do is you're going to monitor the INR every day for the first 5 days. Then, once it's stable, you're going to monitor them twice a week for the next 2 weeks, then once a week for the next 2 months, and then every 2 to 4 weeks after that. Anytime a drug is that interacts with warfarin is added or removed, you pretty much kind of need to start this over with just to make sure. And one last thing is that heparin can interfere with your PT-INR and give you slightly false readings. When it comes to adverse effects, bleeding, obviously. And this is important because these patients are going to be out and about in the community, walking around all anticoagulated like. So they should inform dentists and surgeons of warfarin use before they arrive for the procedure. Also, patients should not use razors. They should use electric shavers. Fetal hemorrhage and teratogenesis are extremely dangerous to an unborn child. So if you know that you're planning on becoming pregnant, you should not be taking warfarin. And if you are taking warfarin but not planning on becoming pregnant, you should take steps to not become pregnant. Warfarin has more interactions than any other drug, and so you have to be very, very careful, as we already said. You want to make absolutely certain that they don't start taking drugs over the counter that they don't know, especially things like aspirin and ibuprofen or even acetaminophen. Monostat, it's a antifungal. You got to be careful about these things. They also have to be careful about their vitamin K intake. It's not that they can't have it. So they're allowed to eat some broccoli, but they can't have a lot of it, and the amount that they have from day to day shouldn't vary too much. So if they're used to eating, let's say, 2 stalks of broccoli a day, and all of a sudden they decide, you know what, I'm going to eat 8 stalks a day, it's going to interact with their warfarin. If they've been eating 3 stalks a day and they go down to 0 stalks a day, it's going to interfere with their warfarin. Warfarin has more interactions than any other drug, and so you have to be very, very careful, as we already said. You want to make absolutely certain that they don't start taking drugs over the counter that they don't know, especially things like aspirin and ibuprofen or even acetaminophen. Monostat, it's a antifungal. You got to be careful about these things. They also have to be careful about their vitamin K intake. It's not that they can't have it. So they're allowed to eat some broccoli, but they can't have a lot of it, and the amount that they have from day to day shouldn't vary too much. So if they're used to eating, let's say, 2 stalks of broccoli a day, and all of a sudden they decide, you know what, I'm going to eat 8 stalks a day, it's going to interact with their warfarin. If they've been eating 3 stalks a day and they go down to 0 stalks a day, it's going to interfere with their heparin, with their warfarin. Okay, now we're going to move on to antiplatelet drugs. In general, antiplatelet drugs are better for arterial thrombi, such as heart attacks, strokes, and peripheral arterial disease. There's 3 basic groups of antiplatelet drugs. We have aspirin, which is a COX-1 inhibitor. We have ADP receptor antagonists. And we have GP2B3A antagonists. If you'll recall, ADP receptors are receptors that platelets have on themselves, and ADP is a substance that platelets release when they're activated. So basically, it's a signal to other nearby platelets that, hey, party's on. And the GP2B3A receptor is the carabiner that's on the platelet that the platelet uses to tie fibrin to itself. So fibrin just doesn't bind to random spots on the platelet, it actually binds to this particular receptor. So if we inhibit that receptor, we will inhibit the ability of fibrin to stick to platelets. So remember that aspirin is going to irreversibly bind to COX-1. Because a platelet can't make more COX-1, that particular platelet will be inhibited for the rest of its life. The endothelium, on the other hand, does not, and it can still produce its prostaglandin, which is anti-clotting, known as prostacyclin. So this selective inhibition of platelet COX-1 is what causes the therapeutic reduction of clotting. If you use large doses, then you're going to inhibit both the platelet COX and prostacyclin production by the endothelium, and then you're going to push the patient toward more clotting. When it comes to the 5-year reading of bleeding risk, so a patient who is on this drug every single day for 5 years, typically there's going to be somewhere between 0.2 and 0.4% of patients who will have a GI bleed. There will be somewhere between 0 and 0.2% of patients who have a hemorrhagic stroke during that time. And if patients use buffered or enteric-coated, it does not reduce the risk, because the risk is not because of the aspirin interacting directly with the patient's stomach. It is because of the aspirin reducing the mucus lining of the stomach. For prophylaxis, and also for stroke and for MI prophylaxis, you're going to use low dose 81 milligrams a day. And for an acute MI or stroke, you're typically going to use an intermediate dose, which is 162 to 325 milligrams per day, which is 2 to 4 times the low dose. Next, we have ADP antagonists. These are going to bind to platelet ADP receptors, which is going to inhibit platelet aggregation. As far as agents, the particular one that you're going to know is clopidogrel, which is used for both MI and stroke and can be used as treatment or prevention. There are some newer ones out there, but clopidogrel is probably still the #1 prescribed on an outpatient basis. As far as adverse effects go, as you would expect, bleeding, but it can also cause neutropenia or agranulocytosis, and it can also cause thrombotic thrombocytopenic purpura, where platelets are destroyed and that leads to bleeding. And the last antiplatelet drug is the GP2B3A antagonist. It revolutionized the treatment of acute MI, and in fact, its discovery was like an amazing breakthrough. Before, we just thought that fibrin kind of stuck things together. But we really didn't know that platelets actually held onto the fibrin by sticking it to this particular receptor. So it was an incredible breakthrough. Yay, medicine. Woo woo! There are 3 particular agents in the United States They're all given IV. They're usually in combination with aspirin and heparin. And the two things they're typically used for are acute coronary syndrome with a patient who has either unstable angina or an MI. And they're also used for percutaneous coronary interventions, which include both angioplasty and stents. Notice that they are never used for prevention. Several different drug names: abciximide, ebtifibitidipidipatide, and tirofiban. The one that we are going to learn is this one, and it's integralin, not integralin, just so you know. If you have to memorize it as integralin, just don't say that in front of other healthcare providers. Say integralin. You'll thank me later. As far as adverse events, bleeding, especially from the site of either the IV or the percutaneous coronary intervention. As far as some other antiplatelet goes, we have dipyrimidol, which is sometimes used in heart valve surgery. If you combine it with aspirin, then it's known as Agranox and is used for TIA prevention in the United States. Again, TIA is transient ischemic attack, which is sometimes known as a mini stroke. We will learn more about them in Patho Pharm 2. Cilostazol is a drug that is not only an antiplatelet, but it's also a vasodilator, and that's useful for intermittent claudication. So remember, claudication is pain in the legs with walking. Intermittent claudication, it hurts when you walk, and then it gets better when you don't walk. It's a sign that your legs are not getting enough oxygen because there's not enough arterial blood flow to those muscles. That's a complication of peripheral arterial disease, which is the exact same disease process as occurs in the heart and in the brain for heart attacks and strokes. Our last subject here is, excuse me, our last subject here is thrombolytics. Thrombolytics are anticoagulants that break existing clots. Now, all of the anticoagulants that we've talked to up to this moment do nothing to existing clots. Now, they prevent the existing clot from getting bigger, they prevent new clots from forming, but they don't actually break it down. Thrombolytics are actually going to destroy the clot. Now, the way that they do it is they are going to enhance fibrinolytic systems. So, fibrinolytic breaks down fibrin. And what stabilizes the clot? Fibrin. Now, there's an important thing here. And remember earlier on, we said that when you have a clot, you're going to have platelets, and then you're going to have these fibrin fibers that are going around, and that those fibrin fibers are going to start forming cross bridges with one another to cause an increased strength. Those cross bridges are fully formed at about 2 hours. So by the time you get to 2 hours after the clot forms, it's much, much harder to cut than if you cut it early on. So thrombolytics are going to dramatically reduce their effectiveness after 2 hours. In order to have maximal efficacy, 2 hours. Repeat after me, within 2 hours. The earlier the better. And the reason for that is there's fewer cross bridges before 2 hours, so it's easier to cut the fibrin. Now, using thrombolytics puts the patient for extreme risk of bleeding, so you have to weigh the benefits of destroying this clot now versus the risk factor of bleeding to death. As far as drugs go, you're going to learn streptokinase and tenecteplase, also known as TPA. So streptokinase is an older, slower drug and it has more side effects, but it is extremely cheap and it also can cause allergies. It actually comes from the Streptococcus bacteria. Its typical uses are going to be pulmonary embolism, MI, and DVTs. Tenecteplase, or TPA, which is tissue plasminogen activator. Yes, the exact same stuff that your body uses to produce that cuts plasminogen into plasmin, and plasmin in turn is the scissors that cuts the fibrin. So, tenecteplase is basically artificial TPA. It is much more expensive, but there are fewer side effects, and it is effective a little bit longer than streptokinases, and it's approved for MI, PE, and stroke. Now, bleeding is the #1 adverse effect, especially into the intracranial cavity, so you got to be extremely careful with these drugs. Time to treatment in MI and in stroke is the most critical thing. Remember, we said it doesn't work after 2 hours, and the earlier you do it, the better. The first 20 minutes is the bestest ever. All right, let's talk about the nursing so what. So, platelets and clotting factors work together to make clots. Platelets hold hands and then tie themselves together with fibrin. The clotting factors make fibrin. Things that promote inappropriate clotting include arterial inflammation, and that's going to lead to heart attacks and strokes. And on the venous side, we have slow blood flow, which is going to lead to DVTs, atrial fibrillation, AAA, and that the main risk factors there are going to be immobility, posture, and physical blockages and defects. Also, surgeries, especially orthopedic surgeries. When it comes to inflammatory disorders, things like systemic lupus erythematosus, rheumatoid arthritis, septicemia, and DIC can also cause clotting. When it comes to preventing arterial clots, you typically want to use an antiplatelet, such as aspirin, Plavix, or Integralin. When you're preventing venous clots, such as DVTs or AFib, then you want to use an anticoagulant. If the patient is outpatient, you can use Warfarin or Pradaxa or Xarelto. If they're inpatient, you might use heparin, a low molecular weight heparin, or if they've had a history of heparin-induced thrombocytopenia, then you might use Fondaparinux, or also known as Arixtra. If the patient has an active arterial clot, then you're typically going to use both an antiplatelet and an anticoagulant, and if it's appropriate, you might use a thrombolytic. If there's an active venous clot, typically you're going to use an anticoagulant. If that active venous clot has become a pulmonary embolism, then you're going to use an anticoagulant and maybe a thrombolytic. If your patient is on heparin, monitor the PTT. If your patient is on warfarin, monitor the INR. When it comes to interpreting these two lab values, you got to know the therapeutic values. If the patient's lab value is less than the therapeutic value, you raise the dose. If it's above the therapeutic value, you lower the dose. End of story. The last thing we're going to talk about is heparin infusions. Now, when you're giving IV heparin, usually it's going to start with a loading dose, also known as a bolus. Then, after the bolus, you're going to start a maintenance infusion. Typically, the bolus is going to be about 4 times the dose of the maintenance infusion. The infusion is going to be with an IV pump and a bag. The bolus is going to be administered with a syringe. Now, both of these are going to be weight-based, so you're going to have to do a little bit of math to figure them out. The problem is going to be 2 steps in each case. You're first going to have to calculate the dose in units based on the patient's weight, which you might have to calculate from pounds to kilograms. And then you're going to have to calculate the dose in mLs, or milliliters, from the unit dose that you calculated in step 1. So here's a sample order for the bolus. A 60 units per kilogram bolus. Our patient weighs 110 pounds. So first we're going to have to find out the weight in kilograms. So we're going to divide the pounds by 2.2. So in this case, 110 divided by 2.2 is going to give us 50 kilograms. Then we're going to multiply the dose per weight by the weight. So you're going to take your 60 units per kilogram and you're going to multiply that by the weight in kilograms. So 60 times 50 is 3,000 units. And if you're doing this out with fractions, you'll notice that the kilograms cancel each other out, leaving only units behind. Now that we know the unit dose, 3,000 units bolus, what we have to do now is we have to calculate how many mLs we're going to draw up. So in this case, our vial says 1,000 units per ml. That's going to be our concentration. Now, repeat after me. Always, 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 always divide the dose by the concentration. So the dose in this case is 3,000 units. We're going to divide that by our concentration, which is 1,000 units per milliliter. Remember that when you divide by a fraction, 1,000 units divided by 1 milliliter, you're going to flip it. So it's going to become 1 milliliter over 1,000 units. And then your units are going to cancel each other out. All you're left with is mLs. And if you don't want to worry about your units, just do the numbers. It'll work out. 3,000 divided by 1,000 equals 3 ml. At this point, you should do what's known as the real-world check. You're drawing this up with a syringe. Most syringes are somewhere between 1 and 10 mLs. If you're giving something like 50 mLs or 100 mLs, you might have the wrong dose. Before we begin here, I just want to say that that patient weight in 110 kilograms is incorrect. It should be 110 pounds. I'm very sorry for that typo. Unfortunately, there's no easy way for me to fix that, so we're just going to live with it how it is for right now. So the infusion works the exact same way as the bolus does. First, in part 1, you're going to figure out, based on the weight per kilogram per hour, you're going to figure out the number of units per hour. Then in the second part, you're going to figure out the number of milliliters per hour based on the units per hour. So here we have a typical order, 14 units per kilogram per hour. And again, 110, it's supposed to be pounds, not kilograms. So we're going to find our weight in kilograms. We're going to divide 110 by 2.2, and this is going to give us 50 kilograms again because it's the same patient. Then we're going to multiply the dose per weight by the weight, just like we did in the first step. So 14 units per kilogram per hour times 50 kilograms is going to equal 700 units per hour. There should be a per hour right there. There's typos all over the place. It's almost embarrassing. This should be infusion. So we know that our 700 unit infusion dose, because of the last slide, and our bag says 25,000 units in 500 milliliters. So the question is, how many milliliters per hour do we set the pump at? So the rule is you always divide the dose by the concentration. What's the concentration in this case? It's 25,000 units per 500 mLs. Now, if you reduce that down, that's going to be 50 units per ml. If you leave it whole, it'll work out the same way. So now what we're going to do is we're going to take our 700 units per hour, and we're going to divide that by 50 units per ml. And that's going to leave us with 14 mLs per hour. Ta-da! At this point, you should do the real-world check. If you're administering something like a liter per hour, let's think about this for a moment. The body has approximately 5 liters of blood in it. If you are giving 1,000 milliliters per hour, you're giving 20% of the blood volume each hour. In 5 hours, you're going to have doubled the patient's blood volume. Chances are you made a math mistake.